Thank you very much to the team at IPHCE for coordinating this session and hosting it as well. I'm Dr. Micah Schleif. I'm a faculty member from Johns Hopkins School of Public Health, and have the pleasure to open this session today and introduce our moderator, Dr. Frehot Negatu. I just want to say a few words about the origins of this course and how it has evolved over the last year and a half or so as the COVID-19 pandemic has evolved as well. This course was originally launched in the middle of 2020 and was focused around sort of the initial response in Ethiopia and around the world, and the role of the health extension program and the rest of the primary healthcare system in Ethiopia in that initial response. Obviously, many things have happened and the pandemic has evolved, and so we have run, this is now the third iteration of the course, and this iteration has some additional content around the vaccine rollout and distribution in Ethiopia and across the African region. And we're delighted today to have several guest speakers joining the session to speak more about the current events related to vaccine rollout and distribution, some of the challenges, and also all of the work that's been going on in Ethiopia and across the region to both ensure that there is a supply of vaccines and then also work with communities in order to be able to address their concerns and ensure that the vaccine demand and uptake is also taking place. And I think we'll delve a lot more into some of the questions from the participants. So it's wonderful to see so many joining and to be able to hear from a couple of experts that you'll hear introduced soon. So it's my pleasure to introduce Dr. Frehot Negatu, who's the Executive Director of the International Institute for Primary Healthcare in Ethiopia and a dear colleague. Dr. Negatu brings a wealth of experience both within the Ethiopian health system as well as a broad expertise both clinically as well as in public health, and we'll be moderating today's session. So over to you, Dr. Frehot, and welcome to everyone.
Thank you, Micah, and welcome everyone. Thank you for joining us on today's session. As Micah has said, we will be discussing about the current important issue that revolved around COVID-19 since the pandemic emerged in 2019. And our today's discussion will be revolving around COVID-19 vaccination rollouts and challenges related to that. So there were many areas around the vaccine that made it so important because this vaccine is expected to cover all the nations across the world, and there are issues related to access, issues related with equity, vaccine safety, also a new emerging issue, which is the vaccine hesitancy. And we have witnessed this, important discussion points during our first session when we introduced this course. There were so many questions from our participants around vaccine-related challenges and experiences that they want to hear, and which made the second session really relevant. And I'm assuming that we have participants from the previous session joining us today as well. And the vaccine development, as you know, is one of the most important findings during the pandemic, because the development was within a short period of time, and it was made available right after the pandemic, hit the world. And aligned to that, the World Health Organization also established kovacs, which is a global collaboration that is created to make sure there is access to COVID-19 test, access to treatment and vaccination. Even though with so many groundbreaking, findings and establishments, the vaccine rollout is faced with so many challenges, which we will be discussing with our experts today. Our first presenter is a presenter from Ethiopia. So without further ado, let me introduce Dr. Mesaret Zelalem. Dr. Mesaret is a pediatrician by training, and she is currently the director of maternal child health, youth and adolescent and nutrition directorate at the Ministry of Health. She has a very vast experience in terms of maternal and child health. She was also the chief of staff for the former Minister of Health in Ethiopia. She has also worked in the clinical world as a pediatrician. She's now leading the COVID-19 vaccine rollout and management in Ethiopia, and she'll be presenting her experience and speaking about the current situation about COVID vaccine in Ethiopia. So welcome, Dr. Mesaret, and over to you.
Thank you very much indeed, Dr. Freud. Can I please share my screen? It's really an honor to happen over this webinar to share my beloved country Ethiopia experience on the COVID-19 rollout. Thank you. Thank you very much, Dr. Frey. I'm going to take you through the COVID-19 vaccine distribution and rollout in Ethiopia. So far, what experience do we have really, and how many of the expected targets has been achieved, and what are perhaps the experience and the challenges that we have. And these are the topics that I'm going to take you through this introduction. Maybe I will just take you through the highlights of introduction, preparedness activities, demand promotion, communication, service delivery strategy, MNE, and implementation barrier. So as you know, in the 13th of January 2020, WHO has already declared the COVID-19 is a public health emergency in international concern, and Ethiopia is reporting the first confirmed case of COVID-19 case as of March 13, 2020, and as of November 7, 2021, there have been like 3.7 million total case has been tested, and the confirmed case has been 366,424, and then the days is exceeding 6,000. I think you have already know the daily trend of the case. This really shows you there was a three blips, the first wave, and second wave, and third wave. We recently experienced the third wave, which is a Delta wave we had. And when we see particularly the preparedness activity, you know, we have started the preparatory activity as of November.
Dr. Mesaret?
Yeah.
So sorry, we're not able to view your slides. The screen is dark right now.
Is that? Sorry. Okay. What about now?
Okay, yes. It's not in presentation mode, but we can see it.
Okay. What about right now?
Now it's dark again.
Yeah.
Sorry. So someone can share for me, perhaps.
Can you share from your end?
Yes, yes. I'm about to.
Thank you. Let me close. Okay.
It's now visible.
Thank you very much. So can you move to the next slide? So we'll see the introduction, preparedness activity, demand promotion, communication, service delivery strategies that we follow, and the coverage status that we have, the M&D part and implementation barriers, and perhaps I'll also show you the way forward. I have already discussed about the background, the global background, and the status that we have actually, how many have been tested and confirmed case, and this next slide, please. And this is the The three blips that we had, three wave, first, second, and third wave, I have already discussed on this. Please move to the next. So when we see the preparedness activity, we started the preparedness as of November 2020. We have a different coordination platform under the leadership of Her Excellency, our Minister Leah. We have the inter-country coordination, all the government focal and also the partners are also engaged in this coordination platform. We have the Ethiopian National Immunization Technical Advisory Group. We have a technical working groups and the regional health bureau partners. And these all are revitalized for the COVID-19 vaccination rollout. And we have already completed the necessary documents like protocols, proposals, the national deployment vaccine plan. We already submitted that one, and we also mobilize resource. We developed the training materials, and we developed different materials for the SCBCC and the community mobilization as well. And also we did the resource mobilization, which is for both financial, different materials and HR. Capacity building training provided at all level, and additional cold chain capacity has been also done for the national level. The current situation is not only a challenge, but also there is an opportunity to invest on our cold chain capacity. We have invested on the central IPSA, particularly ultra cold chain investment has been established as well for Pfizer. Demand promotion and communication has been also started. Please move to the next. And we have already prioritized the target. At the very beginning, everybody knows about the initial concern that we had. It was there was a global shortage of the vaccine, so prioritization was a must. So based on the SAGE recommendation, we have started the phased approach, like the population at risk, the global availability of the vaccine, and the operational feasibility has been the very important indicators to prioritize the groups. And we grouped into phase 1A, phase 1B, and to vaccinate 20% of our population. And the second phase was beyond 20%. So from that on, increased COVID-19 vaccine supply target, we have revised that one. Sorry for the inconvenience. Do you hear me?
Yes, we can hear you, Dr. Masal.
Okay, sorry. So we started the stratification of the target group, and for the first one, we approached the like that, and now we move to revision of all the strategies, and now we started the vaccination for all population, all above 18 years, and also we have recently get advised by the Ethiopian National Immunization Advisory Group, and also we move down to 12 years and above, particularly those eligible for Pfizer. And now children below 12 years will not be considered for other vaccines. It's only for Pfizer because of the global recommendation. Next slide. Next slide. Okay, thank you. The demand promotion and communication, we have started the synchronized launching ceremonies, like we have already conducted both at the national and sub-national level. The top political leaders, including the sub-national state heads and all the political leaders, has been the one championing the first launching program for the COVID-19 vaccination. And the modern religious leaders has been also vaccinated. High-level advocacy has been conducted. Multiple media briefing and press release has been also conducted with a different level. And using the state television and radio with the different local medias, we were also using using a different modality. We are reaching out of our community with this public relation communication, even SBCC. And the media professionals orientation has been also provided. We sensitize the media people. Advocacy workshop has been conducted using a different health professional associations like the Ethiopia Medical Association. The different like 20 associations has been called, and then we have done the advocacy with them. Even we did recently advocacy with the education sectors, with the teachers associations as well. Next. Thank you. This is a showcase that you can see Her Excellency Minister Lia. She is the one taking the lead in Tigray regional state before even at the end of the law enforcement. If you remember, that was the first day that we launched it. And you can see the religious leader and are the one taking the vaccine. This is also, this really shows you how the media briefing and the engagement of the public media is really going on. Next. Next slide, please. Okay, so far we have received AstraZeneca, Sinopharm, Janssen, and Pfizer. So these are in our plate, we have these types of vaccine. So, okay. Can you please go back to the next slide? Okay. So when we see the service delivery strategies and coverage, the service delivery strategy, we use the fixed one, static one, outreach, and mobile, and particularly temporary and fixed one has been established in industrial parks and developmental corridors. And the total of the vaccine that we got is 12.7 million vaccine has been already received. So you can see we have received the 5 types of vaccine. In general, I can say 4. 2 types of AstraZeneca, Janssen, Sinopharm, and Pfizer. So using this, we are also using like a different modality to reach out the community. We have a mobile van vaccination strategy, which we have already started in people when they have a social gathering. We have also prepared completed already the nationwide the COVID-19 vaccine campaign. So we are in discussion with the regional health bureau focal points and the regional health bureau heads with the leadership of Minister Lia. Recently, we have almost to start the nationwide vaccine campaign. So when we see the coverage, since the launching AstraZeneca first dose vaccination, we reached out like to 2 million people, which is the coverage is 93%. From the first dose vaccinated target, 1.3 million, which is 67.4% vaccinated for the second dose. Total dose administered for the second dose vaccine, which is equivalent to 81.5%. So when you see the Sinopharm vaccination administered, the total coverage is 73.4% for the first administered, and the second dose is 65.6%. And for Janssen, we reached out the 66.3% of the target groups from the available vaccines that we have, which is 1.2 million. So when you see the total dose administered with the total vaccinated and fully vaccinated as of November 9th, 2021, you can see a total of 5.1 million total dose has been administered for the 3 times, and total number of people vaccinated are 3.6 million and fully vaccinated are 2.6 million. So I can say for all cases, targets, they took only the first dose. We reached to 4.6% of the community, the population, and when we count for the total completed vaccinated people, we reached out 2.6% of the population has been completely vaccinated. So far, booster doses are not recommended for any type of COVID-19 vaccination based on the different platforms that we have. We ensure the community herd immunity level requires, which definitely needs further investigation, because people might raise the question of like when we see the expected days and morbidity is not as such expected from the forecast. So that certainly demands further research, and we cannot conclude it is because of we reached out the target vaccinated. So that really demands further research, plus to say really fully immunized and the herd immunity is reached. at least 85% of the population has to be vaccinated, the target groups. When you see the M&D part, we have a Google Sheet platform. We track the data through that, and we pilot the integration of the kovacs data management through the DHIS2. We have started piloting in Addis Ababa, SNNPR and Gambela. So for the urban context and the agrarian and pastoralist context, we selected 3 regions. So the piloting to integrate to the DHIS2 is going on. So virtual platform, we certainly use every week, every day, every other day. We certainly use a virtual platform for training, for coordination, monitoring and evaluation as well. And technical assistance and mainly in supportive supervision is going on very well. And interaction review, as you know, this is a very different, a new condition which is going on in the world. You know, we have recently learned from the West Africa, you know, the Ebola outbreak. After that, the WHO is recommending, post-pandemic interaction review. But now the recommendation due to the revised IHR, the recommendation is during the pandemic, there is interaction review. For Ethiopia, we have already conducted with the engagement of every stakeholders that interaction review has been completed, and then we take very important points to keep up, and we see the challenges. We consider that for the opportunity as well. When you see the implementation barriers, you know, there are hesitancies, misinformation, disinformation, and rumors about the vaccine. Overall deployed COVID-19 vaccine uptake is low because at the very beginning, we were expecting to get 9 million vaccine because we have already communicated our public. The startup were supposed to be 9 million, but unfortunately, because of the global shortage, we have already received 2.22 million, the first lot of the vaccine. So that really creates a huge gap. The security issue you see in the northern part of Ethiopia, vaccine supplied, which, you know, the short expiry, this is a worldwide problem that we face. And the COVID supply management is overwhelmed with a routine cold chain system. These are the implementation barriers. So finally, with the way forward and for the possible call to action is, we'll certainly conduct the vaccine campaign. So the regional health bureau engagement and the political leadership is very important. And we will certainly coordinate this one, and supervision and monitoring is very important. The leadership engagement at all level based communication intensification, basically bilateral communication is very important, and intensification of the preparation is also the critical component that I would like to put as a way forward. Thank you very much indeed for the chance, and if you have any question, comment, you can put it in the chat box. I'll get back to you. Thank you very much once again, Dr. Freyot and the team.
Thank you, Dr. Mesaret, for such an insightful presentation, starting from the context and the coordination platforms, discussing about the types of vaccination and the current rollout status in Ethiopia with the coverage, the data management systems, and the current challenge that we're facing both in Ethiopia and globally. So since our second speaker is having a problem with connection and we couldn't reach her, we will start the question and answer session for Dr. Mesaret, and then maybe at the end, if our second speaker is able to join us, we can jump into that, or we can discuss what other alternates we have to hear more from our second speaker, who is from the International Vaccine Access Center. So, Dr. Mesaret, there are a couple of questions in the Q&A chat box. Some of them are technical, but let me start by forwarding a question that revolves around the coverage rate. So why is the COVID-19 vaccination coverage low is the first question, and is that rate acceptable compared to the vaccine that we currently have at hand? And why is the coverage rate for the second dose of the vaccine specifically low? This is the first question that is asked. So over to you, Dr. Masal.
Thank you very much, Dr. Fred, and I appreciate Iman. I see the question has been raised by Iman Kader. Thank you very much for the concern. At the very beginning, I would like to really take you back to the time where there is a huge pandemic going on in India, because the AstraZeneca is the first vaccine that we get support from the COVAX facility. So there was an interruption, even a total, blackout of like sending any medical equipment or supplies from India. So because AstraZeneca is basically manufactured from the Serum Institute of India, so that we are really in trouble to get the second dose, because that was exactly the time where we were supposed to vaccinate those targets who has already taken the first dose. They were awaiting for us to have a second dose, but unfortunately we used the first 2.2 million for the first dose. We were awaiting for the second shipment. Unfortunately, there was total blockage from India. So that was a clear gap that we have really realized. So then after, we were started to discuss and getting advised from the Ethiopian Immunization Advisory Group. So that because there was no vaccine at all. So we were waiting for the second shipment, where there was a total blockage from India for almost close to 4 to 5 weeks. So that due to that, we get advice from WHO, from other expertise. The recommendation was the second dose can be provided even with as long as 14 to 16 weeks between the first and the second. So that was the time we were getting the second shipment, where we were providing to the people. Ethiopia is a very wide geographically country, so that to reach out this community, the distribution must be like at least 3 to 4 weeks and the like. And there was also the second wave happening in Addis. Addis is the epicenter. We were started to contain the epidemic in Addis as well. So that was the issues, why this disparity of the second, the first dose is happening. To say this is acceptable, I cannot say it is not acceptable, relatively acceptable, because at least the people are really trying to get the second vaccine, the second dose, as much as they can. And the other issue was the short expiry, and a small amount of vaccines has been aggregated, so that when I showed you in my presentation the total 12.1 million, which means it's not at the same time that we receive the vaccine. It's one thing is a different type of vaccine. The second is there are a different expiry as well. So this really creates like a challenge. Otherwise, we have understood this is a serious problem. So now that's why now we will certainly undergoing the national campaign as the mid-November. I mean, the third week of November, we will certainly launch the national campaign again. Thank you.
Thank you, Dr. Masarat, for addressing those questions. And I think what you have stated earlier responds to the question about the current expiry date and the issues related with that. And I don't think that is an Ethiopia-specific problem, as you have clearly stated it. It's a global problem, and other countries are also faced with that. There are some questions revolving around vaccine hesitancy, which has been repeatedly mentioned in so many platforms. And this is the issue, I think, currently hampering the vaccine uptake in so many places. And there are questions around it stating whether we have any kind of study in country, or if we have any information about the magnitude of vaccine hesitancy in Ethiopia specific to urban areas. and also what how the misinformation and disinformation has affected the vaccine coverage, and what the strategies are to respond to those challenges. So maybe we can discuss about that and then move to the other questions as well.
Okay, thank you once again, Dr. Freud, and I recognize colleagues that raised this concern. First of all, you know, the hesitancy is not the Ethiopian problem, it's a global issue, because from the first scenario, you see the vaccine has been manufactured over a year period, so that people might question, including the health professionals. So that's why the misinformation, disinformation has been the challenge, not only for Ethiopia, but also for the entire world, even for the first world, continent. This is a global challenge, I can say. So basically in Ethiopia, we try to reach out, like close to 72% of the health professionals and supporting staffs has been vaccinated. So I can say this is not a serious challenge in general, but still, whatever the 1%, the misinformation and disinformation may really matters for the public. Basically, if it starts from the health professionals as well. So that is a big question. So for that, we have learned that, the moment we engaged the community leaders, the clan leaders, and the religious leaders, the people start to, because Ethiopian peoples, we follow one religion, one of it. So close to 99% of the population follow one of the religion. So that one of the religion doctrine. So that after we reach out to the religious leaders and the trusted messengers, we really saw the shift, the high shift of the coverage rate of the vaccination. So that this is the strategies that we follow, and particularly when we start a public dialogue using the public media, like a question and answer, using a different panelist, we see really a dramatic change. So that is well recognized. We have really documented in the interaction review as a member state for WHO region, Africa. And for the first question, I see how is the hesitancy in rural area and the like. In general, this is a big study area where we are working very hard with partners and EPHI, the technical arm, basically the research arm for the Ministry of Health. So that will be revealed once we conducted the training, and once it's finalized, we will certainly use for the policy brief and for our policy direction, plus we'll communicate to the public. Thank you very much indeed.
Thank you, Dr. Mesaret, for addressing those questions and for your explanation. Maybe a couple of questions around, the time between the first dose and the second dose, and what will happen if there's a defaulter who didn't take the second dose for more than 14 months. And these are more of a technical question, especially a defaulter for AstraZeneca, and as well as is it possible to take the second dose of another type of vaccine if you have taken the first dose, for example, AstraZeneca? So these are a bit of technical questions, but I feel like it's very important to address since a lot of our participants are directing this question. So it's more about, mixing the different types of vaccines and what will be defined as a defaulter, and what should be the time between the first and the second vaccine dose. Thank you.
Thank you very much indeed, Dr. Freud and colleagues.
Over to you, Dr. Mesaret.
Okay, thank you very much. For the second dose, the timing between the first and second dose, basically for AstraZeneca, the maximum time which is globally recommended, which we accept, is 16 weeks. So that beyond that, I think no more first dose, it will be started as 0, as a first. The second will not be taken, because that will may not have a value But this is also the other critical area for the next time to, to see it as well. So the maximum time, if you can Google, it's not 14 weeks, it's 16 weeks as well. But we negotiate with 16 and 14 weeks. Then after, I think it's not be taken as a first dose. So that is a recommendation. And in general, the recommendation is 2 to 3 months, which is, 8 weeks to 12 weeks. But because of, the global shortage, there was a global dialogue. What will be the maximum time to tolerate without having the second dose? So the maximum is 14 to 16 weeks. So after that, there is no evidence, so that it will be taken as an almost no or nil. And for the Sinopharm 3 to 4 weeks, for Pfizer 2 to 3 weeks. So that it's good to stick to this current recommendation, but we really don't know tomorrow about the COVID vaccine and even for the COVID infection by itself, because this is a new learning, the new challenge, the new beginning for this century. COVID is a new phenomena for this century, I can say. And perhaps maybe the second question is, can you please pardon me, Dr. Frey?
Just a question around mixing the vaccine.
Mixing the vaccine, okay. Thank you. We really don't recommend that one. We see there are people that are like saying the first dose is AstraZeneca, second Pfizer. There are many things that's going on in the world, but we have our own strategy. We follow that. We are in a place where we don't have excess amount of vaccine, excess types of vaccines that we have. We are in an area where we have shortage of vaccine, I can say, with a different scenarios as well. So that our strategy is to stick to one of the type. If someone is started with Sinopharm, the second dose will be certainly Sinopharm. If it is Johnson & Johnson, it's only one dose. And for AstraZeneca, we don't recommend first AstraZeneca and Pfizer. AstraZeneca will end with AstraZeneca, Pfizer with Pfizer. So that is our current recommendation, but we might really shift based on the pandemic, based on the, the global recommendation, feasible and scientific recommendation, and based on the available vaccine, the epidemiology and the like. Thank you, Dr. Fred, once again.
Thank you so much, Dr. Masarat. Thank you for addressing almost most of the questions, and thank you for giving us a highlight of what's happening in Ethiopia. Actually, it's not only a highlight, but rather a detailed information. So we're gonna jump into the second part of our discussion, which we have a presenter from the International Vaccine Access Center. So I will introduce Dr. Chizova. Dr. Chizova is a public health physician, and she has over 25 years of experience on different projects that were executed in Africa, Asia, and America. Currently, she is the country director for the International Vaccine Access Center in Nigeria, and she is the principal investigator for Gates Foundation funded project in Nigeria. She's also a founder of a local civic society organization called Women Advocate for Vaccine Access in Nigeria. So without further ado, I would like to welcome Dr. Chizova to share her experience around, the COVID-19 vaccine in a different context aside from Ethiopia. So over to you, Dr. Chizova.
Thank you very much for the invitation, and good afternoon, everyone. I prepared a set of slides that will talk about COVID vaccine access challenges. So if I may share my screen, is that okay?
Yes, please, Dr. Chizova, go ahead. But if you find a challenge in sharing, we can see it. Yep.
Okay. So I think I'm able to share my screen. Just to warn you, I've been having unfortunate internet connectivity issues. So I hope it stays on throughout the presentation. So thanks for the kind introduction. What I want to talk today really is about the COVID vaccine access. And some of you may already know the challenges that Africa has had with COVID vaccine access. So I just want to take a look at why this is happening and what we expect to see in the next couple of months in terms of how to improve the coverage of COVID vaccines in Africa. So we know that that the virus, the COVID virus, the SARS-CoV-2, is causing unprecedented health and social damage to the world. Right now, we know that about 5 million cumulative deaths have occurred as a result of COVID. So it's not just the public health challenge that COVID brings that we're concerned about. We're also concerned about the socioeconomic impact of the virus, and it's really been devastating. The World Bank estimates that real GDP growth declined by 3.5% in 2020. Although this is on the uptake, there are other things also that have really been affected by COVID. International travel, for example. I know Ethiopia is one of the biggest sort of travel hub in Africa, and it may have been affected as well in 2020. So and this has led to an estimated 1.5 drop in travel dollars from 1.5 trillion to 3 billion only in 2020. So it's really important for the world to be vaccinated and for Africa to be vaccinated, because vaccines hold the key to curbing the virus, mitigating the health and social and economic impact of the pandemic. And we know that Africa has been relatively spared compared to other regions in the world. However, we do have COVID cases in Africa. We do have COVID deaths in Africa. And vaccination will help to reduce the severity of the cases, the rates of hospitalization, the risk of death, and risk of acquiring the infection, and also the level of population transmission. And this is important because even though Africa is relatively less affected than the rest of the world, if we continue to have continued population transmission of the virus, we run the risk of viral mutations that can produce variants that, virulent strains or strains that would be of grave concern to us. We all know what happened in India in the first wave of the pandemic. India was relatively spared, but when the Delta mutation emerged, then it hit India really bad. So that's a cautionary tale for all parts of the world where we think that we have been relatively spared, that this is not over until it's over. So the next slide, we want to see that because vaccines are such an important part of the solution, we're really concerned about the vaccine inequity that we see. In August, the United Nations and International Monetary Fund, as well as the World Bank and the WHO, called for international commitment and support so that every country would have vaccinated at least 40% of its population with at least one dose by the end of 2021. So what is happening? What is the picture that we see? On the right-hand side, you see this huge disparity in the share of the population that have been fully vaccinated against COVID-19. So at the bottom of this bar graph, you see Tanzania, Nigeria, Ethiopia. Only 3% of Ethiopians are fully vaccinated. Compare that to 98% of people in United Arab Emirates or Portugal or Cuba. So this huge vaccine inequity is of concern. And when you think about low-income countries as a whole, only 4.4% of people in low-income countries have received at least one dose of the vaccine. So we have a long ways to go. Now, the vaccine, for us to get coverage, and to reach equity, I say that there are four sort of basic components that we need to address. We need to address vaccines, we need to address vaccination systems, we need to address the vaccinator, which is the healthcare worker, and we need to address the vaccinee, which is the recipient. So I've been talking about the vaccine, the fact that the vaccine is in inadequate supply, is in unpredictable, is coming in unpredictable amounts, and that has affected the coverage of the vaccine. So that really talks about the international inequity in vaccine access. And you've heard the term vaccine solidarity. You've heard the term vaccine appetite. You've probably also heard the term vaccine and solidarity. So these are the things that we've heard in the last couple of months that demonstrate the fact that high income countries had secured vaccine doses, limited vaccine doses for their populations, and while low and middle income countries were left behind. However, this situation is going to change in the next couple of months, and I'll talk about that shortly. So there's the vaccines. The next thing we need to consider is the vaccination system. So, for the vaccines, we need to think about what is it about the vaccines that will give us adequate doses. We have to talk about research and development. We have to talk about production of the vaccine, procurement and delivery. If all these things are lined up well, then we will have enough doses. What about the vaccination system? We need to talk about the regulatory requirements. When there's a new vaccine, is the country ready and primed to provide the regulatory requirements that will enable the vaccine to be deployed in the country? There needs to be program coordination, cold chain capacity, vaccine deployment, and logistics. And in terms of the vaccinator, that's the healthcare provider, there has to be enough healthcare providers distributed across the country, both in rural areas and in urban areas. The health workers have to be trained, and they have to be ready to provide those services. So that's service provision readiness. And then in terms of the vaccinee, that's the individual. They have to know about the vaccine. They have to trust the vaccine. They have to not be hesitant about the vaccine. And beyond that, they must have the ability to access the vaccine. So distance should not be a problem. And then also they have to be motivated to accept the vaccine, and they have to have reminders. So I'm going to focus on the things that are in red to talk about why the vaccine supply in Africa has been low. And then I'll talk, I think that will be my main focus for this discussion. So why has vaccine access been a problem in Africa? First of all, we are not researching and we are not developing the vaccines because we have not invested in the local science. We've not invested in basic science. We've not invested in vaccine research. When you look at our national institutes of research, how many of them have invested? How many of our governments have invested in our local national institutes of research to give us the basis for the vaccine science? I think we need to do better in that regard. In terms of production, when COVID hit, what happened was that the people or the companies that were able to produce the vaccines that had been developed were companies that were already into vaccine production. So there was insufficient production capacity in the globe as a whole. The world needed about 7 billion doses of vaccines for a year, but the production capacity that was available at the time was less than 5 billion doses. So therefore, there was going to be scarcity of doses. And you would find that as the year wore on, as vaccine production continued, it put a strain on raw materials for production of vaccines. So things like the vials, the bottles that will be used to fill the vaccines were in short supply. And so the constrained supply of raw materials also led to reduced quantities being produced. And then The other thing is the concentration of vaccine production capacity and know-how. In this slide, you will see that the vaccines, it shows the countries that have actually produced vaccines. We're saying China, US, EU, India, UK, Russia, Switzerland, South Korea. It's only recently that there has now been an agreement to produce vaccines in South Africa. Otherwise, Africa is not on the map in terms of countries where vaccines are being produced. So if you are not producing vaccines and there's a global shortage of vaccines, then you are at the mercy of, the market forces. So that's one of the major reasons why Africa has been left behind in the availability of vaccines. The next thing is procurement, right? So vaccines are produced, then you now have to procure them. You need money to procure. So kovacs is that global facility that was set up to ensure that low-income countries have access to vaccines and that they will not be competing directly with high-income countries for vaccine supply. And so what ended up happening was that COVAX was indeed in competition with high-income countries for supply of vaccines. Countries like the US had made advanced investment. They had invested billions of dollars in Johnson & Johnson, in Pfizer, in Moderna, even before the vaccines were developed and designed. So they invested in advance to say, once your vaccine is developed and once it is trialed and found to be effective, we want to be first in line to get the doses. And so COVAX was in competition with countries like the US and with the EU. And then also manufacturers failed to prioritize COVAX for one reason or the other. So low and middle income countries like Ethiopia, Nigeria, and other countries in Africa who had limited financial power to bargain with the vaccine manufacturers found themselves at the back of the line. So these are one of the challenges with procurement. And then, at the end of the day, we find that Africa was at the back of the line. So this slide just shows you what COVAX facility is. It's a facility that is it's an international agreement that is made up of WHO, Gavi, and CEPI, and the goal really is to ensure that they deliver 2 billion doses of vaccines by the end of 2020 to low and middle income countries to ensure and guarantee fair and equitable access to the COVID-19 vaccines. So there are several countries that have signed up to the COVAX facility and have been receiving vaccines from COVAX. So here is a snapshot of where countries have been receiving their vaccines. So COVAX for now is the primary source of the COVID-19 vaccines for countries, for low and middle income countries, and it's also an important source of vaccines for middle income countries. So you can see from the slide here that it shows you the direct deals. So that's when countries speak directly to manufacturers and contract with them to get the vaccine doses. So those are those colored in blue, and then the ones in gray are the doses that are procured through COVAX. So you can see that for low and middle income countries, the gray is quite tall. It means that majority of the vaccines in low and middle income countries actually come from COVAX. So next slide. And then another important thing to point out is India. So India, most of their vaccines actually come from India because India has a strong manufacturing production base for vaccines. Okay, so beyond the procurement, there are also distribution bottlenecks, right? So COVAX receives donations from high-income countries to deliver to low-income countries. But what is happening now is that there are not enough doses coming fast enough. And then also at the point where India was battling with the Delta variant, they put some export control. So kovacs that relied on getting supplies from India could not get that anymore because India needed it for their own population. So here you see the number of doses of vaccines that are promised to be donated by different countries. This data is from September. The United States, for example, has donated 81 million doses, but there are still almost 200 million doses that are promised that are not yet donated. So there is room for improvement in terms of the speed of donation of these doses that will serve COVAX and serve low and middle income countries. So for now, the solution to the COVID vaccine access, COVID vaccine access are donations to COVAX so that they can buy the vaccines, and doses donations to COVAX, and the African Vaccination Trust initiative led by the AU, as well as the development of manufacturing capacity in the continent. I just want to point out one issue that has been raised, which is it's called the TRIPS waiver. It is a proposal right now at the World Trade Organization that is asking for a waiver of intellectual property rights to COVID vaccine and pharmaceuticals at this point in time, so that other countries and other companies who have the capacity can take those the COVID vaccines and produce them with the support of the inventors and the pharmaceutical companies that developed them, that designed them. So this TRIPS waiver has been pushed by civil society organizations. It's still not done yet, but that's one thing to watch out for. If this happens, then it might help to ease the production bottlenecks that we have experienced. Moving forward, I think it's important to recognize that vaccine coverage is not just dependent on the availability of doses. It's also dependent on the uptake of those vaccines. So COVAX is projecting that there will be increased doses in the next 6 months. So we are going to be faced with a different challenge when it comes to coverage. Are our systems ready and available to deploy those vaccines that are coming? That's the big question for us. And then the next question is, are our communities primed to accept those vaccines, to take up those vaccines? And how do we address the issue of vaccine hesitancy? So those are some of the key things that we need to be looking ahead of. We need to ask ourselves about what are the approaches that will be fit for the African continent in order to reduce vaccine hesitancy, improve vaccine acceptance, and then also have the health systems deploy these vaccines in massive quantities without affecting routine immunization. Because we know that routine immunization has been disrupted and other health programs have been disrupted as a result of COVID, and we need to rebuild the systems and reestablish our baselines. So in conclusion, I think it's very important for us to recognize that we're in a global race against the pandemic and that vaccinations will be our escape out of this route. Unfortunately, for now, Africa has been left behind because our access to COVID vaccine doses has been insufficient and unpredictable. If Africa is unvaccinated, the cost will be counted in thousands or millions of lives lost and the strain on the health systems. If the COVID virus continues to be transmitted and it's not curbed in Africa or in any part of the world for that matter, there is a risk that viral mutations can be produced. And this might be strains that are more deadly, more transmissible, or vaccine resistant. And the cost will be high, and it will remain a global threat. So it is therefore in our collective interest to support vaccine solidarity and make sure that all countries in Africa, in any part of the world, have the vaccine doses they need. And then our systems need to be primed and ready to deliver them. And then our communities need also to be ready to accept those vaccines. So thank you very much.
Thank you so much, Dr. Chizova. We really appreciate the presentation and the context you gave, especially related to the challenge and specifically focusing the challenge in our continent in Africa. Maybe since we are a little bit over time from the initial schedule, I would just like to direct a few questions to you, Dr. Chizova, and then we can wrap up our session. So you mentioned a lot of, strategies in terms of addressing the gap in the continent, but can you just highlight one of the biggest thing that you think is strategic to advance the COVID vaccine coverage in Africa? And also, can you say a little bit more about, or a little bit about your insight or your thinking around booster doses in Africa, given the current coverage rate, and where is that positioned for the continent if booster doses are officially accepted and are part of the guideline globally? Thank you.
Thank you very much. So I think for Africa, our focus now really should be on vaccine deployment and vaccine uptake. So how are we going to manage the huge number of vaccine doses that are going to come into the system? If I take Nigeria as an example, when we first received the 3 million, almost 3 million, almost 4 million doses of COVID vaccine way back in March, it took us about 2 months to deploy those vaccines. And it was deployed almost in a campaign style, where health workers were going out to the communities, as well as, of course, the health facilities and everything, going out to the communities and just drumming up support for the vaccine uptake. And that campaign style deployment is costly, is expensive, it's not sustainable. And that covered only about 1% of the population. Now think about if we want to reach 60% population coverage, what that will entail if we are going to use campaign style. It's just not going to be sustainable. So what we need to do is to expand the partnership. So previously it was deployed only in government facilities, but now we're thinking about deploying them, bringing in pharmacies to be part of the process, bringing in private clinics, bringing in, looking at how we can vaccinate in religious institutions, or even looking at companies. How can companies be part of the process of vaccination? So we need to expand the spaces and the places where vaccination can occur. The second thing we need to do is we need to mobilize the community. Right now, I would say there is complacency, there is apathy towards the vaccine. The most people who are looking to get the vaccines now, according to some studies and some conversation, is really people who are required to get the vaccine. So if you're traveling or there is a vaccine mandate in your area, but we need to do much more. We need to educate the public. We need to listen to the public and hear what their concerns are. Many people are concerned about the safety of the vaccine, but we need to show them that millions of people have been vaccinated and there are no major safety concerns. So we need to bring along, I'm sure you must have heard this, traditional leaders, religious leaders. People listen to their pastors, they listen to their imams. We need to get more of them involved and make vaccine champions of them. There is a lot of work that we need to do in order to convince people to take these vaccines. And I believe that in terms of booster doses, if supply is not a problem, then I agree with booster doses. But if supply continues to be a problem, I think we need to initially vaccinate, get people, their first and second doses before we start thinking about booster doses. But if we have enough supply to cover for first and second doses, then booster doses are fine, as far as I'm concerned. Over.
Thank you, Dr. Chizova. Thank you very much for addressing those questions. I know there are a lot of questions within the Q&A session and in the chat box that we were not able to address because of the time constraint that we are having. So we're gonna send these questions to our presenters, and then they will respond, and we'll make sure that we upload the responses in the learning platform. So if you're registered for our course, you'll be able to find the answers for the questions in the learning platform. So thank you, everyone. Thank you, the presenters, and as well as the participants. I'm going to hand it over to Dr. Micah Schleif to wrap up our session. Over to you, Micah.
Thank you so much, Dr. Frehot, and thank you very much to both presenters. Thank you, Dr. Mazeret, for really providing sort of a overview of the trajectory and all of the work that's been happening in Ethiopia, and being able to respond to a number of questions from learners as well. And thank you so much, Dr. Chizova, for providing that bigger overview of some of the work that's being done at the global and regional level to understand supply and demand, and really look at some of the policies and sort of global agreements that are resulting in some of the challenges historically, and also all of the progress that's been made. I just want to say that we will definitely follow up on the outstanding questions, and it's always a great sign when there's more to talk about than what there's time for. So looking forward to continuing the conversation, and wishing everyone a wonderful rest of the day. And thank you for all of the contributions from everyone, and thank you, Dr. Frehot, for moderating the session. So I think with that we can wrap up, and looking forward to staying in touch with all of you. So greetings to everyone, wishing you a safe rest of the day, and thank you.
Thank you.